thank you very much for the invitation and to come, and thanks for sticking it out this to the afternoon so that for this session here. So I'm going to talk about I've been asked to talk about functional tumors, non-functional tumors, and carcinoid syndrome, so that the functionality here relates to the presence of hormonal secretions. And let me see. So, as previous speakers have mentioned, there are neuroendocrine cells widely spread throughout the body, and indeed any of these areas can produce a neuroendocrine tumor. So whether we're talking about the lungs, stomach, pancreas, abdomen, ovaries in women, prostate in men, paraganglia, lots of areas where neuroendocrine cells hang out. A neuroendocrine cell, actually, this is a low power microscope view of the lining of the small bowel, and what they've done here is they've just put on a stain for serotonin. So they're showing the serotonin producing cells. They say it's 1%. It looks like less than 1% to me. So these are very rare cells in the normal bowel. If you cone down further on one single cell, you can show what's being shown here in a high power microscope version view of one of those cells. This is the nucleus where the genes are. These little brown spots are serotonin granules. That's what it looks like under high power microscopy. So, neuroendocrine cell. What is a neuroendocrine cell? It's got the neuro thing, it's got the endocrine thing. What's that all about? So, just a cartoon of a neuroendocrine cell to introduce you to what's going on. There's blood supply coming in. There are also nerve supplies coming in, and hence the neuro part, but I'm not going to talk about that at the moment. There's blood leaving this area. There are a variety of hormones being made in neuroendocrine cells. There are over 20 different hormones, chemicals, that have been shown to come from neuroendocrine cells and tumors. In the normal neuroendocrine cells, they're being produced in the cells. They're jettisoning their cargo out into the blood and having effects downstream. So also on neuroendocrine cells, these are normal neuroendocrine cells. There are somatostatin receptors on the outside of the cell. So those somatostatin receptors are responding to somatostatin and other chemicals that are coming on the blood coming inwards. So neuroendocrine tumors then. As we mentioned, neuroendocrine tumors can be quite widespread in the body, but this slide separates neuroendocrine tumors into a relatively old schema, which is foregut, midgut, hindgut. Foregut includes, interestingly enough, the lungs, the stomach, the pancreas, and the first part of the duodenum. The midgut is where most of the neuroendocrine tumors, over 55% of them, are in the small intestine, which is midgut, and then the hindgut is rectum and part of the colon. But this division into foregut, midgut, and hindgut allows me to just highlight one aspect of neuroendocrine tumors, which is that different tumors in different places can have different hormones being produced. So that the foregut, the lung, and the stomach, for example, can produce a lot of histamine, serotonin. In the lung and thymus can produce adrenal stimulating hormone. The pancreas, although it's a foregut organ, it's a very specialized organ with a lot of different potential for different hormones. It can produce insulin, which is probably best known for in terms of hormones, but can also produce gastrin, glucagon, etc. And then the midgut produces mainly serotonin. It also produces another set of hormones called tachykinins, which I'll mention again. So what is a functional tumor? A functional tumor is a tumor that produces either sudden or sustained production of certain chemicals, which we call hormones, into the bloodstream. Those chemicals from the tumors produce specific symptoms, which we will talk about in a moment. The specific symptoms really depend on which hormones are related by the tumors, and which hormones are released by the tumors really varies by the tumor site and the type of tumor. So the most well-known syndrome or hormonal syndrome present in functional tumors is, of course, the carcinoid syndrome, and we'll speak mostly about this. These come from small bowel, but you can get carcinoid syndrome from lung and stomach. You can even rarely get it from pancreas tumors. Produces serotonin, but also other hormones that I'll mention again. But there are a variety of other hormonal syndromes. Somebody has mentioned Zollinger-Ellison, I think it was Dr. Halfdonisson this morning, producing gastrin. You'll notice that a lot of the other syndromes are from pancreas here. Some of them also ectopic Cushing's syndrome, coming from lung and thymus. Down here, invisible, is pheochromocytoma and paraganglioma. So what is carcinoid syndrome? Well, I think I should ask you all to define carcinoid syndrome at this stage, because you've heard it in a number of other talks. But essentially, one or more of the following symptoms. So 80 or 90% of people with carcinoid syndrome would have either flushing or diarrhea. But other things are wheezing, palpitations, heart failure associated with carcinoid heart disease, and other symptoms. They're caused by the hormones, as I mentioned, mostly when people have liver tumors as well as their primary tumor. There are some tumors that can cause carcinoid syndrome without liver metastases. About 20% of people have these tumors initially. They do tend to, the number of people who have carcinoid syndrome tends to increase over time, just with tumors getting bigger. So how do patients come to present with, how do they get diagnosed with neuroendocrine tumors? Well, many patients get diagnosed with neuroendocrine tumors because it's either an incidental finding, turn 50, have your colon screening with colonoscopy, and a neuroendocrine tumor is found. Have an X-ray because you've fallen and hurt your back and something else is found. Have abdominal symptoms such as abdominal pain, chest pain. All of those ways of presenting are from non-functional tumors. About 20% of people have the hormonal syndromes, so those are the functional tumors. And the issue about this is that people with non-functional tumors have a big problem. They have tumor growth. Their problem is related to tumor, where the tumor growth, where the tumor is present. People who have functional tumors have two problems. They have the same tumor growth problem that people with non-functional tumors have, but they also have these hormonal symptoms. And the hormonal symptoms are a big deal. So this is a nice study, and it's been repeated a number of times. It's a study from the folks in MD Anderson, looked at over 600 patients to see, what really made a difference to them. Was it how big their tumor was, or whether it was metastatic or not, or whether it was that they had symptoms related to functionality or the hormones of their tumor. And what they found was that when they looked at people who had increasing amounts of carcinoid syndrome as manifested by increasing bowel movements, those folks had increased anxiety, increased depression, decreased overall physical function, and they had essentially the same data when they looked at flushing, which is the other big symptom of carcinoid syndrome. So the symptoms really make a difference in how one lives one's life, as many of you know. How do we treat folks with hormonal symptoms? Well, we treat them by, I think there's sort of three conceptual pots that I put the treatment in. One is attack the tumor, just as the same as if it were a non-functional tumor. Two is stop the hormone being produced by the tumor. And three is try to block the action of the hormone, even if it is already produced by the tumor. Attacking the tumor is all that you've heard about up to now today. So you go to see Dr. Koitkin or to see Dr. Howe and get the tumor removed as much as possible. That'll take care of the functional, the symptoms. You starve it with embolization therapies that we'll hear about next. You burn it out with ablation therapies. You radiate it with PRRT, with either the Lutathera or if it's a pheochromocytoma with MIBG or Azedra. You poison it with, now this is, I should put an asterisk here, because as Dr. Chandrasekharan has mentioned, everolimus doesn't decrease symptoms related to carcinoid syndrome, but actually everolimus actually does an interestingly good job at decreasing some of the symptoms of insulin-producing neuroendocrine tumors. The specific treatments, and these are I'm going to focus more on the stop the hormone production and block the action of the hormone today. So the stopping the hormone production is octreotide and lanreotide, and that decreases all of the hormones that come from these neuroendocrine tumors. You can also stop the hormone production by using telotrestat. That blocks one of the hormones, but the main hormone that comes from these tumors, serotonin. And then for people with other forms of, not carcinoid, but pancreatic neuroendocrine tumors producing insulin, diazoxide blocks insulin production. Metyrosine blocks adrenaline production, pheochromocytoma. So there are a group of medications which block the production of hormone. There are also a group of medications which block the actions of hormones. And when you're getting to this stage of blocking the actions of hormones, you're a little bit off the grid in terms of controlled clinical trials. So ondansetron, which you might know as Zofran, very good nausea medication, but it is an inhibitor of a partial inhibitor of serotonin, and has been used as such in carcinoid syndrome. There are agents which block histamine. There are agents that block gastrin, etc. So there are certain medications which can block the action of hormone, but as I say, you're off the grid in terms of clinical trials, and it's on a case-by-case basis and experimenting with one thing or another. So let's focus on carcinoid syndrome a little bit. The main hormonal syndrome that comes from neuroendocrine tumors. There are more than 20 hormones that are made by neuroendocrine tumors. The major hormone that's related to carcinoid syndrome is serotonin. It's certainly the best known hormone of the carcinoid syndrome. It is the main hormone that causes carcinoid diarrhea. It is not the main hormone that causes flushing, as was mentioned already. Serotonin is very important in our normal bowel activities, irrespective of neuroendocrine tumors. Without serotonin, we would have a bowel which does not contract. But serotonin then, when present in excess, gives rise to carcinoid diarrhea. But serotonin actually gives rise to about 50% of the diarrhea that occurs with carcinoid tumors. There are other hormones that cause other parts of the diarrhea. So how do we, going back to our little three-pronged attack here, how do we treat carcinoid diarrhea? Well, actually, before I get there, I should mention that before talking about the specific treatments for carcinoid syndrome diarrhea, I should point out, and others have mentioned this before, I think Dr. Howe, there are certain things that you might notice can cause your exacerbation of carcinoid syndrome, and if you can avoid those situations or take some octreotide 30 minutes before those situations, you can avoid the symptoms of carcinoid diarrhea or carcinoid flushing. I've got a small asterisk here with eating. There are a lot of many people have certain triggers for their carcinoid syndrome. If you have never seen a podcast or a video by Leanne Burns, who is the dietitian at New Orleans for a long time. Should check out her stuff. Great advice on what to eat and what not to eat in a person with carcinoid syndrome. So, starting off with treatments. Octreotide, lanreotide, sandostatin improves both flushing and diarrhea in about 60 to 80% of people. It affects all of the hormones that are produced by these tumors. This is just a couple of the trials that have been shown. This is the urine level of 5-HIAA, which is the urinary product of serotonin from the blood. These patients were given lanreotide as part of the major lanreotide trial, a clarinet. It normalized the urinary serotonin, and it goes up slowly, whereas placebo, it just keeps on rising because these tumors keep on growing. And similarly, we can show that octreotide or sandostatin can decrease the number of bowel movements per day, either of them over a period of many weeks, and there's similar data with flushing. So these agents will take care of diarrhea and flushing. One thing that I should mention, and that Dr. Chandrasekaran mentioned in regards to progression of tumors, is that there are some data showing that just increasing the dose of octreotide or lanreotide will improve carcinoid syndrome. So this was a retrospective study from Dr. Strasberg, over 200 patients, but almost 200 of them had either flushing or diarrhea in the 3 months before going up on their dose of sandostatin, mostly going up from 30 to 40, but sometimes up farther than that. Essentially, 80% of people get benefit from taking more octreotide or lanreotide. Some people will use short-acting octreotide in addition to the monthly injection as an alternative for this. So increasing the dose is one opportunity to get rid of the symptoms. So starting at a lower dose, increasing the dose if insufficient control of symptoms. The dose can be increased in terms of milligrams, or we can decrease the time from 4 weeks to 3 weeks to 2 weeks if your insurance company allows it, and sometimes adding on the short-acting is helpful. Zermelo, talotrostat, different medication which is helpful in diarrhea. This is your dietary protein gets broken down into tryptophan and amino acid. Eventually, a small amount goes to serotonin. In carcinoid syndrome, lots of it goes to serotonin, so less of it goes to protein or niacin, vitamin B3. Zermelo or talotrostat blocks that effect and decreases the serotonin back towards normal. And what what happens when a person takes Zermelo is that the number of bowel movements decrease when compared to placebo. A couple of practical points to remember about Zermelo are telotrestat. It's used in addition to octreotide. It's better absorbed when taken with food. Short-acting octreotide can decrease its absorption. Discontinue it if constipation arises. If there are side effects, start slower. It can take 6 to 10 weeks for it to really have its effect. There are differences between telotrestat and sandostatin. They both decrease serotonin. They both decrease diarrhea. Telotrestat does not influence any other hormone. I'm not sure that it influences flushing at all, maybe very occasionally. It may very well decrease carcinoid heart disease. That's an area of current research because serotonin causes heart disease. There are studies on whether it influences tumor growth. We know that octreotide does influence tumor growth. Very important point, not all diarrhea is carcinoid syndrome, and this has been mentioned already. So there are people who have bile salt diarrhea because they've lost their gallbladder or ileum, small bowel bacterial overgrowth, need antibiotics, they don't need more octreotide. The side effects of these medications, they need pancreas enzymes, they don't need more octreotide. Other drugs that people are on, I have many patients who after going through a lot of this, we discover, or I realize that they're taking something like metformin for their diabetes, the diabetes that the sandostatin and lanreotide have increased, and when we take them off the metformin, their diarrhea goes away. So important to reconsider what's going on. As I mentioned, there are some sort of off-label uses for other medications which may have an influence on diarrhea. Also, diarrhea, there are non-specific antidiarrheals, which I use all the time as well. Flushing. Flushing is a more specific carcinoid syndrome effect, and it's actually also frequently more difficult to manage because I think we have less medications for it. This just points out that in the foregut, in flushing that occurs from a lung neuroendocrine tumor or stomach, these people can have flushing for hours. They can have lacrimation, tearing, swelling around their eyes, and that is a histamine effect. The midgut tumors, the more common tumors, the ileal tumors, tend to be the kinins, tend to have a shorter effect. How do we treat flushing? Again, attack the tumor, same deal. Octreotide and lanreotide, same deal. Off-label use for clonidine as a trial. Block the action of the hormone. Histamine blockade can be helpful in some people. I use Zyrtec and Zantac because I can remember the double Z, cetrazine and ranitidine. Also remember, not all flushing is carcinoid syndrome, so a bunch of drugs can cause carcinoid syndrome. It's important to reevaluate things before jumping into going further in carcinoid treatment. Other hormonal syndromes. I mentioned to you some of these other hormonal syndromes. Stopping the hormone production, octreotide or lanreotide will do that. I mentioned the diazoxide metyrosine, and then blocking the action of the hormones. So in gastronoma, blocking the eventual issue, which is the acid. Dietary effects on insulinoma, including using raw cornstarch, which is a very slowly absorbed glucose. And that is the last slide. And thank you very much for your attention.